Good afternoon, everyone. Thank you for joining the webinar today. I'm Dr. Lily Mosha from Malaysia. I will be chairing the session today, in which I'm also the deputy chair for OSEA, Oceania. Professor Talangsa is currently in Fiji, so he is not be able to join us. Or is he around, Professor Talangsa? Okay. So in the meantime, because we need to check technically whether the presenter is already dialed in. Dr. Faiza and Dr. Salman, are you have already? Yeah, so today we have presenters. So Ahad, are they coming dialing in?
Yeah, so she's just joining. Just take her probably 3 minutes. She's just trying to dial in. There's some definitely technical. She'll be here. She's on the line. I've just talked to her. She's just coming
Okay.
in. So just be 2 minutes.
Okay.
Um, in the meanwhile, thank you so much for giving us this opportunity, and my sincere apologies for this wait. But hopefully, we should be up and running within the next 2 3 minutes. I've just talked to her. She's just logging in right now. Hopefully, it'll be resolved.
Okay, so for today's CPC, ISPD, ISN, ISPD, we have with us presenters from Pakistan, which is Dr. Faiza Said and Dr. Salman Imtiaz. So I hope the audience will just wait for a while because of some technicalities issues. And this session will be, the topic will be on looking beyond the obvious, the unexpected guest. So I think there'll be two cases presentation for this session. And so we just wait for a while.
Yeah. Absolutely. As you mentioned, I think we've got two cases, and
Mm,
and just that I just don't want to give any hints or things like that. It's sort of looking at when we see a cloudy bag, what do we think? And more often than not, it is what it is. But in our case, it was something else, and we just would wanted to discuss with the group that do you what would you do in that situation, and are there any clues to how you would take things forward? Um,
okay. For the audience information, Dr. Ahad Qayyum is a consultant nephrologist from Bahriatan Hospital, Lahore, Pakistan, and he is also involved in preparing this case.
Absolutely. And if you wish, if they do not show up in, let's say, the next 1.5 minute, if you wish, we can start, and I
Yes,
can start with the presentation so that, in the interest of everybody, there's no point in
yes.
everybody was waiting. Is that all
Yeah,
right?
yeah,
We
that
have
will
to
be
wait
good, Ahad.
only
Yes.
60 more seconds. By any
Yeah.
chance, do you have the presentation, or should I upload it on my end?
Yeah, maybe you can, so you can control the
Okay, let me
slides.
just let me just put it up. Give me 1 second. Oh, Pfizer's here. Great. Okay.
Yes. Hi,
Okay.
Faiza.
Great.
You're muted, Faiza.
Yeah, you
Muted.
mute.
You're muted, Faiza. Okay.
Assalamu alaikum. I'm extremely sorry for this.
Yes, Waalaikumsalam. So we have the presenter already, Dr. Faiza Said. She's a consultant nephrologist from Indus Hospital, Karachi, Pakistan. And maybe we can proceed for the presentation, Faiza.
Yeah,
On
just give me two
again the
minutes. I'm
top.
just opening it. Just
Yes,
2 minutes.
on looking beyond the obvious, the unexpected guest. You can share the slide.
Okay, can everybody see my slide share?
Yes, yes,
Yep.
we can.
Okay, so greetings everyone. I am Faiza Saeed. I'm a consultant nephrologist at the Indus Hospital and Health Networks, Karachi, Pakistan. And thank you for giving me the opportunity to present today. Today's talk is about recognizing those situations when our first impression may not be the correct one, and hence the title Looking Beyond the Obvious, the Unexpected Guest. Proteus. I chose Proteus here because I think it perfectly illustrates what our patients have taught us. So, in Greek mythology, this is Proteus. In Greek mythology, Proteus was an ancient sea god who's known as the old man of the sea. He possessed the gift of prophecy but avoided revealing the truth by constantly changing his form. Uh, he changed because he wanted to he changed because he didn't wanted to deceive actually. He wanted those who were only who would look carefully could uncover the truth. That's why he used to change his forms. So, just like that, in medicine, our patients sometimes do the same. And the diagnosis isn't hidden, it simply changes its appearance as the disease evolves. So, our challenge is to recognize this transformation. Let me start with a simple question. When you see cloudy PD fluent, what is your first thought? Anyone from the audience? Can we have a little interaction here with the audience?
Yeah, yeah.
May I?
Yes, yes, please.
Yeah.
Go ahead.
Yes. If fluent is cloudy, the first thought is likely a peritonitis. That's the first thought we came in our mind. PDS
I think
associated.
Yeah, I think almost everyone would agree to having to be thinking about infectious peritonitis at the first instance, and I completely agree with that too. And this is exactly what we showed actually initially. And but today's presentation is about recognizing when the clinical story it begins to diverge from that diagnosis. So I'd like to share two patients here from our PD program whose presentations challenged one of the strongest diagnostic reflexes we have in nephrology, especially with the PD patients. So our first case is a 25-year-old male with newly diagnosed end-stage kidney disease, secondary to small-sized kidneys of unknown etiology. He opted for peritoneal dialysis as its maintenance kidney replacement therapy and was initiated on the treatment in February 2026. There was no significant past medical and surgical history. Medications at the start of peritoneal dialysis were bisoprolol, nifedipine, sevelamer carbonate, alpha calcidol, and erythropoietin. His urine output in 24 hours was around 500 ml, and his PD prescription was quite standard. That is, we initiated him on 3 exchanges of 1.5% solution, 1500 ml of the infill volume, and each dwell time was 4 hours. Approximately after 2 months, he developed abdominal pain and cloudy fluent. His workup was sent, and according to the ISPD guidelines, and his PD fluid DR showed WBCs of 449. His initial gram stain came out to be negative, and later on, when we chased the differentials, they were 78% neutrals. So, and his culture was we sent his cultures obviously, and we initiated this patient on IP, cefazolin, and ceftazidime. But the response to this therapy initially in first 5 days was not that good. The fluid still remained turbid. On day 5, his abdominal pain persisted and his effluent was like this. So the turbidity still persists. Again, we sent her his fluid DR, CS, and special cultures. The DR on that day showed worsening WBCs. That was 2,394 with neutrophilic predominance, and the gram stain came out to be negative. And thinking the cultures which were sent on the day one, they also came out to be negative, the initial cultures. So we thought of treating this culture negative peritonitis with IP vancomycin. And he responded well on it, and the fluid started clearing up on the seventh day. On day 7, his PD fluid became clear and his abdominal pain subsided. And so, on clinical grounds, we continued his vancomycin and planned to give it for 2 weeks. So I think by this time everybody would agree, would have treated this patient the same way. By the 10th day, he again developed cloudy fluent, and this time he had no abdominal pain. So this was his PD fluid at that time on the day 10, which is quite turbid. So we repeated his DR report, thinking this is some sort of a resistant culture negative peritonitis, or there's a recurrence. So on day 10, we got his DR report, and it came out to be having WBCs of 304, which was previously in 2000s. And since he responded clinically well and the fluid completely cleared, we thought that WBCs have gone away. So if you compare it with that, you might see it as improving. But then again, since his PD fluid became turbid again, so we believe that these are something new. So his initial gram stain came out to be negative, and the culture which was sent on the day 5 also was negative. So what from the audience, I would like to ask, what would be your next step here? Are you going to, what would you do now? Would you continue with the same antibiotics? You're going to change, or you're going to do something else? May I have any answer from the audience?
So is there any suggested answer from the audience for Dr. Faiza? What would you do next after day 10 when the PD fluid become turbid again? Anyone? Someone in the WhatsApp says, did we check for fungal? Have we checked for fungal?
Okay. And may I have a few more answers?
Yes, before Dr.
May
Faiza
I
reveal.
know?
Yes.
Hi. May I know what is the cause? Have you identified the cause of peritonitis?
Sorry?
Whether what is the cause of the peritonitis?
Course,
Whether there's a
initially,
breakthrough technique or
I think what you're asking is the cause of the peritonitis at this point.
pause. Yeah, we're going to discuss that.
At the point
We
at this
have
point,
another slide to discuss that. I think we
all
just
right. Okay.
stay on the
Dr.
same the
Kamal
question.
too?
Kamal
Yes.
wants to say something. Yeah, go
Yes,
ahead.
Kamal.
Thanks, Fiyad, for an intriguing case. Kamal Sood from Sydney. Look, this patient is a young male who's just started PD 6-8 weeks ago. Is that what it is?
2 months back.
2 months, yeah.
initiated
So
on
about
PD
2
2
months
months
ago,
back.
and has developed this inflammation in the peritoneal cavity, which is obviously there's leukocytes and there's neutrophils. I would think infections, if it's not bacterial, then fungal or tubercular infections would be one thing to consider. It'll be very unlikely for fungal infection to occur so soon after starting PD. Usually, the risk factors are multiple episodes of infections or having received antibiotics without an antifungal prophylaxis. Tuberculosis would be something that I would certainly consider. I would also think about some non-infective causes of inflamed peritoneum. And in someone like this, especially who started PD, very recently, I would think about eosinophilic PD peritonitis. And sometimes the laboratory will not tell you whether there are eosinophils. They will, the automated counters that are there in the lab will only detect these as neutrophils unless you actually ask for eosinophils.
Yeah.
So I would think about a eosinophilic PD peritonitis. The other very rare possibility, and the PD bags certainly don't look like that, is Kyle. And someone who is on a calcium channel blocker, I think Kyle should be, again, a condition, something that you should consider way down in your list, but certainly in your list with the calcium channel blockers being known to cause Kylus PD peritonitis.
So thank you, Dr. Kamal. Yes, so as you illustrated it really well, and I didn't want to reveal the diagnosis, but yes, so the next step should be if your laboratory has gives you a chance, you can order the differential counts if it is available, so you can get a differential counts. So that's what we did. So but before we move on, I would like to, this is actually the time when the story changes and the Proteus might be changing his form. So if you see it through the ISPD approach, we would know with the culture negative peritonitis, what they recommend is you continue with empiric antibiotics initially, you reassess in 72 to 120 hours, you review cell differential counts, and then you repeat cultures as well. And as you said, consider non-infectious causes. If there is high eosinophil, culture remains negative, high eosinophil counts, and clinical response is not as expected. So this time what we did was we ordered the differentials again. And the report came out to be quite striking. Can anybody interpret this PDDR report for me? Anybody from the audience, please? I'm sorry, I really wanted to keep it interactive and I want to talk less. That's why I'm asking questions. So can anybody interpret from the audience? Can anybody interpret this report?
Hi, Dr. Faiza. Ali here from
Hi.
Malaysia.
Oh, how are you, Ali?
Good. So, just to add on the earlier part, I think I would also think of possibility of tuberculosis, yes, and also non-tuberculosis, mycobacterium, also a differential. But like as you have put on here, the differential actually pointing towards predominant eosinophils and fair bit of lymphocyte and monocyte. So the striking here is the predominant eosinophil in the differential. So, yeah.
Okay, so this means that the biological pattern is changing here. In fact, has completely changed. So this was the moment the Proteus has changed its form. Do you remember Proteus? I spoke about in the first slide. So the patient actually is no longer resembling a peritoneal bacterial peritonitis here, and so that's why we're not anymore tempted to continue the same continue to treat the same original diagnosis. So what would be your next step here when you see such high eosinophils and lymphos and more? Sorry for that. What would be the next step after seeing these differentials? So what we did was, okay, let's move on. So what we did was we stopped vancomycin. I wanted to ask whether any one of you would have continued it. So I wanted to have answers from the audience on this, but if we keep on delaying, because I'm already late for the presentation, so I don't want to delay it. So let's jump on to the treatment options here. What we did was we stopped the patient's vancomycin and we initiated this patient on antihistamines. And strikingly, the fluid started clearing in the next 48 hours.
Faiza, sorry, can you explain why at day 5, after day 5 with vancomycin, the patient responded in terms of the PD fluid clearing this account?
In terms of clinical, clinically, the patient responded really well. The abdominal pain went away. The PD fluid, it became clear, completely clear. We could read through it. And so that's why on the basis of clinical response, we didn't even repeat the DR report at that time. And we plan to continue IP vancomycin.
So do you think
apparently responded well?
Yeah. So do you think initially he had infection, which responded well to vancomycin and subsequently developed eosinophilic peritonitis? Because to
Yes.
explain why it cleared.
Yes, we initially treated because there was neutrophilic predominance and they were quite high, like 83%, 78%. These were the neutrophilic percentages in among the WBCs in the DR report. So we treated as culture negative because the culture kept on coming negative to us. So, but we stopped vancomycin here when we saw a very large number of eosinophils here as a large percentage, more than almost 50% of the total WBCs in the DR. And he responded well to antihistamines. So his PD fluid on day 12 became like this. And on the basis of that, we continued the antihistamines for 14 days in total. But this was not the only case. We had another patient who was a 3-year-old girl with biopsy-proven minimal change disease and steroid-resistant nephrotic syndrome, had failed to achieve remission despite multiple immunosuppressive therapies. Her renal failure progressively worsened and leading to chronic kidney disease. She presented with anasarca to us and along with anuria. Her medications at the start of her medications at that time on presentation were alpha calcidol, calcium acetate, erythropoietin, soda bicarb, and some multivitamin syrups, iron and folic acid supplements. So we started her on acute peritoneal dialysis in October, and she was started on low volume short cycles initially with 1.5% glucose fluid, but she had an inadequate ultrafiltrate. And looking at her clinical appearance, she was completely, she was very, very fluid overloaded. She had anasarca. So we switched her fluid percentage, glucose concentration from 1.5 to 2.3 on day 3. The very next day, within next 24 hours, she developed fever. She had abdominal pain and the PD fluid became cloudy. So as per the guidelines, we sent the workup and we saw the initial DR report, which contains of only WBCs. We get it in 1.5 hours time from the lab. So we got these WBCs and were 464. So thinking this is peritonitis, we started her on IP cefazolin and ceftazidime. But we looked up for the differentials. We always do that for all our patients. So we looked up for the differentials, and here you go. There's a lot of this 52% of eosinophils here, and there were negligible or very less neutrophils, and the monocytes were also 24%. So what pattern are we seeing here again? It's the same eosinophilic pattern with high monocyte count. What does the monocytes and lymphos tell us, by the way? When we have high lymphos and we're treating a bacterial peritonitis, and the next DR report, the turbidity has gone, for example, and the WBC count has started coming down, and you see high lymphos, and then you see high monos. What do you think that represents? Anybody? Okay, so are we having any answers from the audience for monos?
Someone responded in the message tuberculosis.
Okay, so lymphos, high lymphos maybe, yeah, but when you're treating initially neutrophilic peritonitis, that was in the previous case, and this time we saw high monos here as well. So these are basically inflammatory cells, and lymphos often tell you that when the patient's bacterial peritonitis is being treated, and when it's going away, the lymphos surge to a bit. And monos.
So sorry, Faiza, your lymphocyte is 90%
No,
or
no, no.
9%?
Yeah, it's 9. It's 9. I was actually referring to the previous case as well. I wanted to keep the two cases together.
Okay.
So here you see high monos, right? So monos are also inflammatory cells. So with inflammatory, this pattern is also inflammatory with high eosinophils.
Out of curiosity, may we know what was the peripheral eosinophil count? Because in certain labs, including Malaysia, our lab do not have differential count for peritoneal PD fluid, but we refer to the peripheral full blood count eosinophil. So
Yeah, we actually looked up for that, and you're talking about complete blood count, right?
Yes.
And the differentials in the CBC. So
Yes.
yeah, we looked up for it, and surprisingly, we didn't find any high eosinophils there. So I didn't mention it here. I had looked up for all the basic labs we could do on these patients. So, but we didn't find anything striking to mention here. So there were no eosinophils in her peripheral blood. So this DR had a negative gram stain, and later on the cultures also came out to be negative. And looking at the eosinophils, we started this patient on antihistamines, and we switched her back to 1.5% dwells. And the response was fluid still stayed turbid, and her abdominal pain also didn't go completely. So on day 3 of the event, we actually repeated the DR because the turbidity was not going away, and we were curious whether we were treating the right thing or not, because antihistamines were not working properly on her. So we got the differentials again, and the WBCs came out to be almost similar to the previous report. And here you would see the neutrophils have completely gone down to 3%, and eosinophils have gone really up. Like, how many of you have seen eosinophils this high in a DR report? 74%. Has anyone seen? So this was a very high eosinophil count, and looking at her clinical status also, which she persisted having abdominal pain, and she wasn't well, apparently, because she being a child, she would cry and all. So we gave her a low dose steroid course along with the antihistamines. And after that, her abdominal pain in the next 48 hours completely got relieved, and the fluid also became clear. So this is perhaps the most important slide of this presentation right here. I think these two patients appear to completely unrelated patients, right? One is an adult, the other is a child, and both have different etiologies leading to CKD. Both were initiated at different times. One had acute peritoneal dialysis, the other had like quite a few months of it, and then presented. The clinical, they seem unrelated, but if we stop looking at the patients and we start focusing on the actual presentation of these patients, we would find similarities were very obvious. So both had early PD. The early PD period is within 3 months. So both presented in early PD time. They both had a culture negative peritonitis. And if you look at the subsequent cell counts, we would find high eosinophil counts in both. Both were not responding well to antibiotics, and both finally responded to the anti-inflammatory drugs. So there were two different patients, but same inflammatory fingerprints, and both had a very good outcome that we did not remove the catheter in any of them, because they responded really well. So individually, if we see these patients, they look different, but the different forms of the proteus beneath the changing appearances was the same underlying truth. So this is where the pattern recognition becomes very important. Rather than you keep on focusing on the protocol reflexes, it's important that you see the pattern here. Acha. Let's go back to the question we had, which Dr. Kamal had illustrated really well. When you see a PD cloudy effluent, what is your first thought? So if you look at the differentials, as Dr. Kamal said, we had cellular and non-cellular causes, right? So cellular has polymorphonuclear leukocytes. It has different reasons to it, like infections, mostly eosinophilic, has dialysate eosinophilia, chemical peritonitis, and we have high monocytes, which may be present in the dry abdomen. After a prolonged peritoneal rest, RBCs can be hemoperitoneum, malignant cells, like if the patient has lymphoma or peritoneal metastasis. Then if we revise the non-cellular causes, we would know that there might be fibrin, which is causing this, and has triglyceride, that is chyle, which is basically because of calcium channel blockers, lymphatic obstruction, and acute pancreatitis. So I would like to go through a quick review of the ISPD diagnostic criteria for peritonitis. The ISPD says that we should have at least two of the following among the three. So we, in the clinical features, abdominal pain or cloudy effluent, then we have dialysate WBCs of more than 100 or 50% polymorphonuclear cells, and positive dialysate culture. Either of these three, if two are present, you call it peritonitis. And this algorithm is, I would say that our patients followed the same algorithm as I have found from the ISPD guidelines, that if you see a cloudy effluent, you suspect peritonitis, and that's what we did. And you start patients on empirical antibiotics, and then if the cultures came out to be negative and there is persistent cloudiness, you look up for the differential counts. And if you find high eosinophil count, that is more than 10%, you call it eosinophilic peritonitis. So our patients also followed the same pattern. So it means the diagnosis was eosinophilic peritonitis. But before we move on to discussing eosinophilic peritonitis, I would like to ask from the audience, among these two cases, what do you think are the causes for eosinophilic inflammatory responses in case 1 and case 2? Can I have a few answers, please? I mean, I think the causes are very obvious, but I still want to listen.
Anyone in the audience would like to answer what are the possible trigger factor for the eosinophilic peritonitis? Dr. Faria Moon in the WhatsApp mentioned chemical irritation. Another person is either antibiotic induced or plastics of the plasticizer from the PD bags.
Okay. And
anyone
and
else?
No. Okay. So both these answers are right, but we also thought that there could be the high concentration of glucose in the second patient, like case 2, because as soon as we switched her from 1.5 to 2.3, she responded like she became all symptomatic, and within next 24 hours. So it could be, definitely the reasons could be as stated by Dr. Faria here. But that was also one thing which was in our mind, that there may be high glucose concentration which is troubling her. Okay, so this is a slide where I would like to discuss a few special points here, and I wanted Dr. Salman and Dr. Ahad to to participate in it. And as I wanted to have insights from their experiences. I am not sure whether Dr. Salman is here because we were mistaken. We have mistaken the session for evening. So, Dr. Ahad, I would be grateful if you could, have some discussion, and of course from our senior faculty here. So, are we actually over treating the culture negative peritonitis? This is my first question. What do you think?
Okay, I have one question. Sorry, for the first case, so
Yeah.
do you think that the patient had eosinophilic peritonitis from the start, or he developed along the way because he was given empirical and then vancomycin?
Okay, if you ask me what I actually thought on the patient, it was related to vancomycin. Initially, we thought that because of high neutrophils, but when we searched on the literature, it states that when somebody has eosinophilic peritonitis, you can have high neutrophils in the initial phase when the eosinophils are actually building up, because there's all complement activation and everything which causes the eosinophil counts to come up. So you might have high eosinophil counts. So that was our literature search was, but I wanted to know, there might be like you guys might be treating eosinophilic peritonitis more than we did. So what do you think about it? Are we actually over treating culture negative peritonitis, or what?
I mean, I think there's a clinical conundrum in the sense that when you do have, I mean, there's a subtype there also that sometimes, as you say, with delayed hypersensitivity, you get exposure to all this glucose and this plastics, and sometimes the response is coming after 4 days. So I think you can't say for sure, but based on what we were seeing in the case, I think everybody would say it's the vancomycin because you gave it and it started developing. Theoretically, what goes through my mind when I saw this case, when you discussed it, was that, okay, so maybe it's delayed hypersensitivity. Initially, it presents as neutrophilia, and later on, it became like that. But I think I think anybody would, the reasonable response would still be that no, this is the vancomycin. And I think Marjorie actually alluded to a very, very important question. And the question that she alluded was that let's say it happens again, would you reintroduce the same antibiotic or no? My response to that would be that I would stay clear of the vancomycin. There's other gram-positive coverage there as well. Maybe I would go with cafazolone and things like that, and that is what I would use in that case. So yeah, so are we over-treating culture-negative peritonitis? I think purely from a Pakistan perspective, what I would say is that, we need to work with our labs really, really well, doing extended cultures and looking for other things as well. But based on what you are saying, culture negative could be easily, eosinophilic one. And, lo and behold, that is what we are treating. But, common things are common. So, yeah, I would put the vancomycin as that cause. And in the second case, because it happened right at the outset, it was the plastic or the high glucose concentration. By all means,
Okay, so this means you're trying to say that we need to actually balance out on the presentations, right? And it's not bad to initially treat it as culture negative peritonitis. And we actually did not complete the ISPD recommended course line for the antibiotics on the case one, because we thought this is linked to vancomycin. So that's why we didn't even continue the rest of the antibiotics, because we thought that it's purely eosinophilic, and he responded really well. So yeah.
But
We treated him. If you look at if you recall the slides, you would remember that we only treated him for on the 10th day. He presented again with the cloudy fluent, so we stopped on the 10th day. So we actually treated only for 10 days, and the recommendation is that you treat it for 15 days at least, 2 weeks.
And you would agree that that is something when we see on the rounds that would scare us really bad, that it's back, the infection is there, and we're going to remove the catheter. So yeah, so it's a great case that way, that we're thinking that please do look at the eosinophils. You never know what's happening over there.
Yeah, you should look up for the differentials. Absolutely. So when do you think antibiotics should be stopped? So I think this should be individualized. What does the rest of the faculty says? Dr. Lily, what do you think?
I think once you've confirmed the diagnosis of eosinophilic peritonitis, then we should stop the antibiotics. Of course, now we're thinking if vancomycin is the culprit causing the um, allergen, then that's why he responded. So in my opinion, in my clinical practice, I would stop once the diagnosis of eosinophilic peritonitis where you started the antihistamine or plus minus steroids.
Okay. So, are eosinophils a biomarker or an incidental finding? Anybody from the audience, what do they think? If you look, if we are having eosinophils, do you think it's a biomarker or an incidental finding in the DR report?
Anyone in the audience? I think it's interesting, Faiza, that your lab managed to do the differential count of the PD fluid. Can you share with us what type of, I think there was a question just now, so what type of reagent that are being used to identify this by your lab to do this to make sure for the eosinophil in the PD fluid able to be reported?
I can share that later on.
Okay.
I can ask them and I can get back to you on that.
I see. Okay.
Yeah. So actually, if you look at eosinophils, we would just know that these are strong biomarkers to tell you that this is not bacterial peritonitis, right? They don't surge up in bacterial peritonitis, but these are not stand-alone diagnostic markers. But they would just suggest that there's something else going on, some other inflammatory pattern. So we should always look beyond the WBC, the sole WBC counts. We should look up for the differentials. So that's why they are important. So should we be more cautious with the PD solutions and early exposure?
When you say more cautious, what do you mean? What do you mean? We should
As
be
in,
more...
when somebody is being started on PD, and and we are using whatever PD fluid brands are available in different countries, and should be more cautious with certain what do you say, the PD solutions, and should we be more thinking of eosinophilic peritonitis in the early phase if somebody comes up with the cloudy fluent abdominal pain and maybe fever? So
Okay, so I mean, just for the clarity of everybody, do you mean like should we be cautious in which brand we use for the PD solution? Is that your question?
not exactly brand, because we know that PD fluid, the plastic and all, they can itself be irritants. So if somebody gets cloudy fluent, should we be more cautious with that? And we think of we should be working on the differentials more aggressively rather than thinking of one diagnosis, which is infectious peritonitis in early phases, early PD time, especially asking for the early PD time. Yeah. And if there's a change in the brand, maybe, yeah, some patients respond differently to different brands.
Okay. Anyone? Yeah, sure, go for it.
Yeah, maybe I just, in my opinion, different patients behave differently, especially in maybe different part of the world or different PD units. And because like in our center, chemical PD practice is very, very rare that we tend to see them. But if you tend to see them more frequent, then you have to scratch your head. Is it because of the PD solution that your patient tend to be more what do you call it, hypoallergenic, or the other thing is because there's a center where they notice that the patient is having reaction to the PD catheter, the brand of PD catheter, where they noted that after PD catheter insertion, before PD training, many of the patients develop chemical PD peritonitis. So I don't think that of course we have to be cautious, but not cautious to say that.
Too cautious, yeah.
On
So
PD.
that's only because the peritoneum is also vulnerable, when you're starting on it, and then you need to, it's just the importance is that you need to have this thing in your mind that you should look up for the differentials. Like if somebody is having peritonitis or peritonitis like symptoms in the early PD phase, you should at least think about it. So,
Okay. There's an interesting, sorry, before that, there's an interesting question in the WhatsApp group. Did you all rule out protozoal worms of helminth infestation in the patient?
okay, we for the child, yes, we actually we didn't we sent a culture stool report, but we didn't find anything. But still, we dewormed her because children, they usually get these bugs in the belly, and that we did that. We actually dewormed her.
Okay.
Okay, so the last question from the discussion points, and we have to discuss on eosinophilic peritonitis as well. So the steroids versus antihistamines, what and when to choose? So the answer to it from my end is that most of the times the response comes when you remove the trigger, right? And if you have recognized the trigger, you remove it, the response really comes in. But there's no, as such, I didn't find any literature on it that what to start and when to start. There's no specific timings for it. Some have given, we gave it for 14 days because a lot of case reports, I looked up for the case reports for the duration of these anti-inflammatory drugs in these patients. And I found out that a few of them have given it for 14 days, and they've, like, just to cover for that, though the patient has responded early in their cases as well. But some has given these anti-inflammatories for 4 weeks too. What do you think, Dr. Lily, or anybody else from the audience? Have they experienced, what is their experience? Because we don't find any guidelines on these.
I would start antihistamine first
Yeah.
to see the response. If there's no response, then only we start them on steroids. And agree, we tend to give the patients about up to 4 weeks of steroids, low dose steroids.
Okay. So we gave them for 2 weeks, and we started antihistamines, and then one of the case was not responding, so we switched her to steroids. So eosinophilic peritonitis, I'll just rush through because I know that we are running out of time. And eosinophilic peritonitis is generally defined as eosinophilia that constitutes to more than 10% of the dialysate leukocytes, or an absolute eosinophil count of more than 100 after exclusion of infection. Commonly, it presents as cloudy fluent in an asymptomatic and patient who is new to dialysis. It's basically it's a reaction pattern, it's an allergic reaction, and typically happens in early PD phase. The causes which I found from the literature was it could be secondary to icodextrin, dialysate exposure, glucose degradation products. We have a few. I have searched up for literature on these two. We'll be discussing in the next slide. Endotoxin contamination, intraperitoneal medications. It could be new PD catheter, as Dr. Lily said, and then idiopathic. If we I have tried to put in some studies on this presentation on the etiology and the historical background of the etiology. And in 2019 this paper actually it actually illustrated the importance of the complement pathway in having eosinophils here in the dialysate during the early PD period. So that is within first 3 months, you can have it. It can be triggered by complement activation from the catheter insertion or the PD bag stuff. Then there was this chemical peritonitis. There was heat sterilization, as I said previously, that causes glucose degradation products. These glucose degradation products are actually acetaldehyde, formaldehyde, and others. And there was an outbreak of 21 cases of chemical peritonitis. It was linked to acetaldehyde concentrations in the bags, and the whole lot was called back from this single lot. Actually, it was a single lot, and it was called back. And GDPs, they also causes ultrafiltrate failure, neovascularization, fibrosis. So there are many things they contribute to, and uh, uh, in the peritoneum. So there was another study I found on the eosinophilic peritonitis in children, and they found out there was it was between the incidence of eosinophilic peritonitis and bacterial peritonitis, and the eosinophilic peritonitis. The conclusion was that it did not differ by age, and high incidence of eosinophilic peritonitis was there in infants, which might be associated because of the high incidence of surgery. But that needs to be validated in further studies. Then we have there was outbreaks have been linked to contaminated dialysate, and in 2002 there were peptidoglycan contaminated icodextrin, which was called back. There was a global outbreak and it was called back, but later on it was seen in 2004. There was the icodextrin, which did not contain the peptidoglycan. It showed no recurrence with the icodextrin. But icodextrin itself can also cause eosinophilic reaction, allergic reaction. So it's not the product only that is peptidoglycan, but it can itself cause the thing. And then we have these were the outbreaks. We have for a few more studies. Several case reports have also been described, case series actually, for intraperitoneal medications, particularly vancomycin. It's very common to have vancomycin allergies. And importantly, all these studies, they all share a common observation, and patients fail to improve with continued antibiotics. But once the offending trigger was removed or anti-inflammatory drugs were added, the dialysate started clearing rapidly and the patient responded well. The pattern is remarkably similar to what we observed in our two patients as well. So after understanding the eosinophilic peritonitis a bit, we are more interested in knowing how do you diagnose it confidently, and then how do you manage it too. So we have already previous slides, and during the cases also, you have to rule out infectious peritonitis for the diagnosis, a diagnosis of exclusion for that. And typical clues are new PD solution, icodextrin, IP, special IP medications, like we have in one of the cases as IP vancomycin. Failure to respond to empirical antibiotics, as the ISPD has also recommended, that if that is the case, you need to think of an alternative diagnosis. Then you have low neutrophil fractions, and macrophages are monocytes when they enter into the PD fluid, and you see more predominant macrophages and low neutrophil fractions. So if you is there a question from anyone up till now? Okay. So
sorry if I just to share, Professor C.C. Zito from Hong Kong mentioned that in their center they do not treat and just repeat the PD culture regularly, and most of the episode resolve spontaneously. So that's the other way of
that's what the
managing.
literature says.
Yeah.
Yeah, so this is it's as you see my management slide here, the first line is that it's typically self-limiting, right?
Yeah,
So you
yeah.
discontinue offending agents and it can be stopped. But since these were first two cases of our PD program, we have a very limited number of patients. So we got really this thing, okay, we need to treat this. So though we stopped the offending agents, which we thought were the culprits, we stopped those. We removed the 2.3% solution in the other child, but we started on the antihistamines as well. So you can give antihistamines and steroids as discussed, and there is no catheter removal is required here. Usually it's like, the response is very good. So if you compare the infectious and eosinophilic peritonitis here, both can be presented as cloudy effluent, both can have abdominal pain. It's more predominant with the infectious. Fever is more predominant with infectious, but can be present with eosinophilic. Then we have more neutrophils in infectious peritonitis, and more eosinophils in eosinophilic peritonitis. Both can be culture negative, but infectious has culture positivity as well. Both the infectious peritonitis responds well to antibiotics, while eosinophilic responds well to anti-inflammatory drugs. It's a poor response to antibiotics. So if you look at the ISPD Pearl slide here, you suspect eosinophilic peritonitis when there's a repetition of all this because we need to. That is the motto of the presentation. That you should know that when there's persistent cloudy effluent and negative cultures, and eosinophils start rising, there's more than 10% of the dialysate leukocyte, and there's poor response to antibiotics, and the presentation occurs early after the PD initiation, you should have one of the differentials as eosinophilic peritonitis. So the take-home message from my presentation was the cloudy effluent is not always infection. PD fluid differential is critical. And eosinophils strongly suggest allergic process. Early recognition prevents unnecessary antibiotics. Always reassess when the cultures are negative. So the key lesson from this is simple, that even in the familiar clinical settings, look beyond the obvious and consider the unexpected guests. So I would like to share this picture. It shows two clouds. The sky told me a story once of two clouds, one which carried the rain and the other which didn't. It means that not every cloud carries the story of the rain. Some just are drifting illusions. Sometimes the cloud is not infection, it's just irritation, as we have in our patients. Before I conclude, I would like to express my sincere gratitude to everyone who contributed to this work and to our peritoneal dialysis program. And I would like especially to thank Dr. Salman and Dr. Ahad and Dr. Lily. Your invaluable mentorship and continuous guidance and support has really added to my professional growth. And I'm really grateful. And thank you all once again for being very kind enough to listen to us, listen to me. And I would be happy to have any questions if they have.
Okay. Thank you very much, Dr. Faiza Said and Dr. Ahad Kayum, for the insightful and interesting case presentation just now. And I think in future, like you said, we always need to think about your protease, which you mentioned just now, where they keep changing in their presentation. So the next webinar, I think will be after Cape Town. We need to discuss with Golf or Professor Talangsa, and I hope that we can see everyone or meet everyone for those who will be attending ISPD in Cape Town. Thank you very much. So before we leave, can we just on your camera so we can take a photo? Okay. Okay. Thank you very much. Have a good
Thank
day,
you.
everyone. Thank you. Bye-bye.
Thank you. Bye.